Thank you. Good afternoon. Well, life is not so simple, and sometimes simplification makes life more complicated. The topic is about AHA guidelines for diabetic dyslipidemia, but Hari has actually discussed the entire guidelines and not focused on diabetic dyslipidemia. So purposefully, I have also kept some slides because I know this is going to happen, so that I can show you real piece of evidence. Caucasians have made guidelines for their own country. We are just using for the sake because we do not have guidelines. But that does not mean we should start using them blindly. We got independence 65 years back, but we are still slaves by our mind because we does not have anything. So whatever they say, it has been made to believe us that this is a truth, but this is a half-said truth. So I am going to speak against the motion. These are the new guidelines. And new guidelines have raised lots of controversy, and there are some reasons we have to wait before we use these guidelines throughout. This slide has been discussed. We know we have treated patients because of these goals and we are very much comfortable, but the guidelines says there is no need for the goals. So what is new in the guidelines? There are no goals. They stress only on LDL cholesterol. Non-HDL cholesterol do not exist. They have identified entire population into 4 groups and they have given a new calculator. So there is a paradigm shift from what we are doing from years to a new policy where there are no goals and we have to forget about non-statin based therapy and non-HDL groups. These are the 4 groups. Just kindly focus on these 4 groups. All of us will be fitting into one of these categories. It means all of us are practically going to be started on statin therapy from tomorrow, according to these newer guidelines. So no specific treatment goals for LDL and non-HDL is totally neglected. Can I practice the same in Indian guidelines? So this is the question. Can I practice the same in our Indian patients? Case scenario 1, I will discuss case-based approach. I will not show you many of the studies. Mr. AB, a 51-year-old man with newly detected coronary artery disease, no history of diabetes, hypertension. The rest of the things are given as recommended. Atorvastatin 80 mg is given. This was the lipid profile initially, and after 2 months, still LDL cholesterol is 110 mg per deciliter. Now these trials do not tell us what to do for this patient who after maximum intensive statin therapy and who is at a risk of recurrent ASCVD still have an LDL more than 110. And previous recommendation says that LDL should be less than 70. So what is the evidence? Now if you see all the trials, primary prevention trial and secondary prevention trial, there is a steep curve and this curve plateaus at around 70 mg per deciliter. The trials were not planned in the past because nobody knows what is ideal goal, what should be the cutoff. But this information we have received from these trials where 70 is found out to be an optimal goal and LDL cholesterol should be kept less than 70 in patients with diabetes or patients with diabetes and coronary artery disease. So we have some evidence, and not only that, if you see follow-up of LDL cholesterol, assuming that there is no gradation in residual risk is irrelevant. The totality of data constitutes a strong rationale for targeting LDL, and removing LDL is one of the basic flaws. Patients no longer have a goal to strive, and LDL goals provides a scorecard to help patients with their lifestyle. Moreover, if patients have difficulty in taking the standard doses of statin, these guidelines do not address that issue. Another important limitation is non-LDL based therapy is totally neglected. But if you just see the recent publication from Improve It trial, it has clearly shown that addition of ezetimibe decreases future coronary artery disease and NNT was only 50. So now we have recent evidences where it has been shown that statin based therapies are useful. Now coming to actually this case, which is actually our talk, a 63-year-old woman with diabetes, fasting lipid values are 160, HDL 34, triglyceride 285 and calculated LDL 76 mg per deciliter. Now based on this guidelines, a 10-year estimated risk is 10.2%. According to the new guidelines, it should be put on 80 mg of atorvastatin. Now how many of us who are sitting here and with LDL cholesterol of 76 are willing to start 80 mg of atorvastatin in this lady? Probably none of us. And this lipid profile is not uncommon in our Indian patients where primary abnormality is hypertriglyceridemia and low HDL. And let's see the evidence. There is a study which is collaborative atorvastatin diabetes study group, where atorvastatin only 10 milligram is used, and in this study was terminated prematurely because there is 37% reduction in composite endpoints of cardiovascular events. And unfortunately, this new guideline says 10 milligram dose of atorvastatin has no role in treatment of such patients. I fail to disagree, and I believe the patient which I have shown you, which is a real world patient, there 10 milligram of atorvastatin dose even is sufficient. Now coming to the other limitations, what about patients who are less than 40 years of age? These guidelines do not address those issues. We have lots of type 2 diabetic patients who are less than 40 years of age. What about patients who are more than 75 years of age? No issues. Using new risk calculator, Hari has shown you new risk calculator, but if you read fine prints of this calculator is not designed for Asians. Apart from that, there is a number of residual risk which remains even after giving statin therapy. Statin only reduces your risk by around 20%. So you have a residual risk of around 60 to 70%. And it has been shown that non-HDL cholesterol is a better CV risk marker than LDL cholesterol. And if you see meta-analysis, it has been clearly shown that for 1 SD increase in non-HDL cholesterol, risk of CV events are much more higher as compared to 1 SD increase in LDL cholesterol. So the strength of association is greater for non-HDL cholesterol rather than for LDL cholesterol. I am different from my Caucasian counterpart. This is ICMR in-depth study which has clearly shown that Indian patients have predominant abnormality as low HDL, high TG, and high LDL is seen only in around 10 to 11% of the patient. And why so? If you see, as TG level increases more than 250, 85% of the population is large, small, dense LDL particle, which is more atherogenic. And the reason is described here, which we can skip. Accord and field, Hari has hurriedly mentioned, they failed to show the benefit. But if you just see the subgroups of the patient, subgroup analysis clearly shows that in a subgroup where TG levels are more than 200 with HDL less than 40 in males and less than 50 in females, there is significant 26% reduction in mortality. If you see Accord trial, again in subgroup analysis where TG levels are more than 284, there is an impressive 31% reduction in CV mortality. Statin and risk of diabetes easily said, no, we have not to look for this issue. 13 trials which have looked into statin therapy is associated with 9% increase in risk. What about high dose statin therapy? See, clearly compare the therapy. We always talk about beta blocker, but we immediately follow statin based therapy. What about high dose statin therapy? Now this is a trial which has shown that high dose statin therapy is associated with increased risk of diabetes. And in Jupiter trial, only 1.9-year patient has marked increase in risk of diabetes. So average duration of diabetes, average age of the subjects in meta-analysis was 59, and you need only 2.7 years of exposure to high dose statin before you identify a new case. We are only seeing a tip of the iceberg, and individuals who are at relatively low risk, many questions needs to be answered before we start statin therapy empirically as a primary preventive modality in all patients with diabetes. Now this is primary prevention cohort. This is calculator. I am a bit faster because I have to cover lots of slides. This is the calculator which has been shown. But can we ignore all these risk factors? Asian race, family history, blood pressure, HbA1c, BMI, waist-hip ratio, CKD, duration of high-intensity statin-based therapy. Nothing has been addressed in this risk calculator. And apart from that, even from their own country, they have said that this risk calculator is based on an outmoded data. It overestimates your risk. So probably the risk calculator is not so robust and should not be used. Apart from that, not only that this risk calculator overestimates, it also undertreats the patient. This is again a real world patient where there is a strong family history of diabetes, premature coronary artery disease, and this young chap has deranged lipid profile, but he is only 25 years of age, and according to the risk calculator, his CV risk at present is only 3.1. And if we have to wait for at least 33 years before this chap would be put on statin therapy. So not only overestimate this risk calculator, also underestimate the risk. So there are a lot of criticism. It is not only me who is criticizing it. It is Americans who have given the guidelines. They are also criticizing it. Guidelines provide limited recommendation for multiple groups which are highlighted here. Apart from that, But ACC has American Association of Clinical Endocrinologists. They declined to endorse these guidelines because there are questions and concerns regarding scientific basis of these guidelines. These guidelines are highly restrictive regarding database considered and omit much newer information. No new research after 2011. Considerable number of at-risk patients are omitted. Incompatibility with existing one, and a new risk calculator which has been proposed is actually based on outmoded data. So ACC at present do not endorses these guidelines. Apart from that, National Lipid Association declined to endorse these guidelines. And after the publication of these guidelines, NICE in 2014, they have given a new guidelines. Before starting lipid modification therapy for primary prevention, take at least one lipid sample. Kindly concentrate on this line. This should include measurement of total cholesterol, HDL cholesterol, non-HDL cholesterol and triglyceride. Fasting sample is not needed. LDL is nowhere mentioned. If you do non-HDL cholesterol, LDL is automatically included. After that, JBS, Joint British Society 2014 guideline have come up. Non-HDL cholesterol measured from a fasting blood sample as total cholesterol minus HDL is a better predictor of future CV event than LDL cholesterol. To conclude with, major concern are flawed methods and inferences. This will translate into massive statinization of the population. Pharmaceutical industry might be happy, but at least as a clinicians we are not. Goals are important. They provide a scorecard to help patients with lifestyle and dietary changes. They provide healthcare provider a guidance in making treatment decisions and focusing on single patient rather than focusing on population. Patient-to-patient differences in responses to medications are common, and without repeat testing, there is no way we can identify the non-responder. There is a suggested caution where we should not strict adherence to these older guidelines. It is better to take a hybrid approach, and this is my belief. This is going to be one of the either greatest achievement or one of the worst disaster of medical history. In fact, in US already a committee has been constituted which is looking into these guidelines to reframe or to issue a statement over and above these guidelines. To conclude, fresh thinking rather than predetermined or predictable thinking is required, because practicing medicine is an art of interpretation of science and its application to human behavior and disease. Thank you very much.